Ready?
Yeah, it's hot.
That's hot, cool. Mine's 185 degrees, thanks to True Dylan. Good morning, everybody. This camera's really weird. Dr. Ulm here, back with Dr. Muse. We're going to talk about stenosis today, but I'm starting us on a clock here. So just so that you guys know, we will not ramble. Clock's going, bro. So what was the topic?
Going to talk about stenosis today. So we've talked a lot about the derangement and some of these things that we see a lot, but we don't only work with the young athletic population in here. We also work with patients of all ages, including in the later stages of life. So we thought it'd be a good idea to talk a little bit about stenosis today.
Yeah, and this is a common one that we see consistently. It's a challenging one though, because it is, well, what stenosis is basically a fancy word for narrowing. So you can have narrowing of an artery, you can have narrowing of a spinal canal. The one that we're going to focus on today is, of course, narrowing of the spinal canal. And there's a few different kinds of stenosis that we'll come across. One of them is called neuroforaminal stenosis, which is fancy Latin for hole that the nerve hole, neuroforamen. Nerve hole. So stenosis of that, you've got these two holes on either side of your spine. So you have the big thick part, the vertebral body in the front, and then behind that is called the neural arch. And inside that is the spinal cord, and out of that comes the actual nerve roots that go to the rest of the body. When you have narrowing of one of those small holes, the neuroforamen, that's called neuroforaminal stenosis. And we see that. I would say, we'll explain like kind of how all this happens in a second. But that is going to present before what's called canal stenosis. And the canal stenosis is when the actual column or canal in which the spinal cord is housed actually gets smaller. And the lack of size, the lack of room can cause all kinds of symptoms from, your classic, I can't walk for very long, I'll get my feet will hurt, or my calves will start getting like this burning and aching in them. People with stenosis are going to tend to be, over 65 years of age. They might have a very, very pronounced arch in their low back. But that's, in general, think of stenosis as narrowing of the spinal canal and or of the nerve hole, the neuroforamen. And, since it's a bony change, it's a structural change, you might think, well, if it's a bony adaptation or its actual structure, how are we going to fix it? Well, the answer is ties into function.
Yeah, so it's a structural pathology with a functional underlying reason. So you don't develop stenosis overnight. This is years and years of development. And I may expose myself here a little bit. Whose law is that? Is that Wolff's Law?
Wolff's Law.
Yes.
Nailed it.
Boards.
Part 4 boards. Nailed it.
So Wolff's Law, if you stress a bone in a certain area, it's going to create more bone. That's the way that the body's going to kind of protect us and basically fortify the bone in the area. So that could be a good thing, it could be a bad thing. So in someone who, let's say, over the course of their life, maybe they spend more time in extension or compressing that back part of the spine.
Extensions when you arch your back a little bit more. I do this rather well.
Yep. So someone who's doing that over and over and over again, maybe they have an occupation that forces them into that, or maybe that's just functionally how they stabilize, which we talk about a lot here. Over time, that competitive compression or approximation of those two bones together form more bone. So then we get that narrowing, that stenosis of the nerve hole. And then we start getting symptoms like...
We use Latin in the medical field so that we can sound smarter than we actually are. So neuroforamen sounds much more
I have a presentation at a medical conference coming up on the nerve hole.
Oh,
so,
cool.
Yeah,
Great.
But so then over time...
Be sure to say nerve hole that whole time.
So when people are standing straight up, they say, yeah, that's when I have my symptoms. So like my recent patient who says, I can stand and walk, but I have to be on the grocery cart kind of bending forward.
Which is like what we would say your hallmark sign. They'll say you can walk, but then if you get your symptoms in your calf or whatever, the moment you sit down, they quickly abate. Or if you walk, you have to sort of like lean forward. So if I'm standing up, that's going to be extension for a lot of people. And then as you walk, you take a step, that might extend you even more. Back to the Wolff's Law that he was talking about, that repetitive load to a bone, in this case it's the actual back part of the spine, that's going to aggravate the symptoms and perpetuate more thickening of that bone. So if you lean forward, you actually take the pressure off of the bone there, and then either the spinal cord itself or the nerve roots themselves get a little bit more oxygen to them, because the reason that they actually get symptomatic initially is actually from ischemia, which is sort of like a lack of oxygen. So they can't actually get blood flowing back up to the heart, and then they can't get oxygenated blood, which is why it takes a little bit of time for it to come on. Leaning forward opens up that area, takes the pressure off, and allows the blood to start flowing again. The nerve gets oxygen, and then that weird achiness that you're getting in your calves and your feet goes away.
So the answer is flex everybody with stenosis, and that's the answer?
Good. Look at him. Mackenzie certified doc.
Okay.
Go.
So with that in mind, you would say, okay, if bending forward's the fix for a lot of these people, then the way we would treat is to flex everybody, but that may not be the answer for every single patient. We still got to go through the exact same Mackenzie exam and see how do they respond to different movements.
He's being kind of a penis here, because if someone responds to extension, even though they have stenosis maybe on their MRI or their X-ray, that might not be what is causing their problem. So that's a nice little, we'll just leave it at that, because when you have somebody come in, you want to make sure that the doctor that you're seeing is basing their diagnosis off of a thorough exam and not just off of a picture they took of your spine or your knee or whatever. So that's what he's making reference to. We have to do a thorough exam to confirm that, yes, stenosis is the problem.
Right.
But how would we just classically, let's just say it is a classic stenosis, and let's say that they are a flexion responder in Mackenzie. What are we going to do? Because remember, it's a bony change. So we're not going to do anything in here that's going to actually change the structure, and yet we can have really good success with these patients.
Right, so that kind of takes us back to the pathological result, but functional underlying reason. So we got to look at function now. Is this someone who has been sitting in that extension, compression, stabilizing strategy where they just compress the back part of the spine when they go to stand up? If that's the case, then okay, we got to start working on how to teach them to stabilize more efficiently. And that's where we get into some of the DNS stuff we talk about, the diaphragmatic breathing, where we teach you how to utilize the diaphragm to create that pressure in the abdomen, offload those tissues in the back that are causing that compression, and then teach people how to move throughout the day a little bit better.
Yeah, if you want to sort of put people into different buckets or different functional blocks that we might work with stenosis, one of the big ones is the strategy that they use to stabilize their spine. And how you stabilize has a profound effect on how you move. This stenosis case is really an example of someone stabilizing what I would say pathologically, right, with a strategy that causes problems over many, many years. So one of the big things that we have to do is sort of go back and reteach them how to stabilize well. But then there's a lot of other mobility things that we can do where we can improve how they move around the structural abnormality of that stenosis. And some of the big areas that we're going to go after are going to be the thoracic spine, which is where your ribs attach, and then also the hips. If you're walking and you take a step, you need to do what's called hip extension. That's where your knee kind of goes behind you. If you don't have sufficient hip extension range of motion, every time that you step forward, your hip flexors actually pull your spine into extension, thereby aggravating the stenosis. The same thing with the thoracic spine. If you've got more of that rounded over posture, that kyphosis we would call it, then when you try to stand up or you reach up overhead, because you can't actually extend through your upper thoracic spine, you're going to arch your low back more. So even though there is a structural change in the lumbar spine in this case, or in the cervical spine, sure, by improving how well that they move around that dysfunction, you can oftentimes completely abolish their symptoms, even though we haven't done anything that's going to change the structure.
Mm-hmm. And I don't know what your thoughts are on this, but if it's the structural pathology, this may be something that we maintain and we got to work on for the remainder of dealing with this condition. So that may be like where I talk more about, okay, here's your spinal hygiene for the day. It's like brushing your teeth. Work on this a couple times a day, and then let's just see if we can just make it a maintenance thing. You work on your own and keep the issues away. So
yeah, there's exercises that they'll have. There's lifestyle modifications that they might have, but there's a lot of things that we can do to actually improve and in many cases completely abolish symptoms, despite the fact that it is a structural pathology. So look at us, 30 seconds left. You got anything else to add, sir?
Oh, no, we got 30 seconds. We can talk about whatever you want.
Let's talk about, man, now you put me on the spot. I was going to say coffee. Let's just talk about the fact that we just nailed it here. I think we're going to finish with that.
Yeah, the big thing that we want to give away with the stenosis talk is it's a pathological thing, but if you have a good functional exam, you can definitely get over the pain that is associated with it and live a much better pain-free life with it. Nailed it.